Hi friends, now we are going to discuss important topics and few important images for coming June FMG. So first image is vagal nerve stimulation. Yes, this is used for treatment resistant depression. Treatment resistant depression in which 4 trial of antidepressant therapy has been failed, then you will think of vagal nerve stimulation because this is invasive technique. We stimulate vagus nerve and we found that stimulating vagus nerve can improve the mood. Question is asked that which vagus nerve is stimulated, right vagus or left vagus? This is left vagus nerve. Which part of left vagus nerve? Cervical part of left vagus nerve is stimulated. And this vagal nerve stimulation was first used for intractable seizure. Second image is projective test of personality. Projective test of personality. Projective. Common projective test, Rorschach test and thematic apperception test. Rorschach test, you are aware there are 10 cards. 10 cards. And these 10 cards have symmetrical image. Look at this. They are symmetrical image. Okay. So, patient is asked, yes, to describe these image. Some patient would say that these two bears are dancing. Another person would say these two bears are fighting. Means depending on the inner feeling, the patient will project, yes, on these images. These feeling will be projected on these images. That's why they are called projective test. Thematic apperception test, also called TAT. Again, projective test of personality. There are 30 cards. This may be a question. 30 cards. And these 30 cards are based on real life situation. And in this, patient is asked to tell a story. Depending on his inner feeling, patient will tell the story. That's why it is all again called projective test of personality. Okay, so catching point is that whenever you find a question in which you will find free associate or projective test and there is symmetrical word, whenever you find the word symmetrical, the answer would be Rorschach test. So a psychiatrist sits next to patient, shows the patient a series of symmetric design. Series of symmetric design means 10 cards, okay, and ask patient to free associate, freely tell what he is seeing, okay. The test is being administered, that is Rorschach test. In thematic apperception test, patient is asked to tell a story. So let me show you few images of Rorschach test. All you can see they are symmetrical. They are symmetrical. So word symmetrical is very important in many clinical question. Yes. Now we come to next image, that is image of electroconvulsive therapy. Electroconvulsive therapy. One potential question, ECT. Now we say modified ECT. ECT may be of two type, direct ECT. Previously used, yes, we used to put electrode directly without general anesthesia, without muscle extent, that is direct ECT. Question, direct ECT is completely banned according to Mental Health Care Act 2017. Now you can't give direct ECT. Modified ECT, in modified ECT, what we do? We give general anesthesia to the patient, we give muscle extent to the patient, and means we modify the ECT. That's why called modified ECT or indirect ECT. Question is asked, general anesthesia, most commonly used methotrexate or anesthesia of choice, methotrexate. Muscle extent, succinylcholine. What is the, yes, electrode placement? Question is asked where electrodes are placed. That is bitemporal, yes, frontotemporal, bitemporal, yes. If you draw a line from tragus to outer canthus, from the midpoint of this imaginary line, yes, 1.5 inch above, we put the electrode, and these are bilateral electrode placement. This picture shows bilateral electrode placement. In ECT side effect, most disturbing side effect is memory loss or amnesia. And question is asked that retrograde amnesia is more than anterograde amnesia, and this is totally reversible. Totally reversible. But we are concerned with this amnesia. That's why we have tried unilateral electrode placement. Unilateral electrode placement, that is right frontal area. Yes, if you want to put electrode unilaterally, you will put at right frontal area. These electrodes are for EEG. Yes, we monitor. Yes, as you know that we have already given muscle relaxant, so there would be less seizure. Yes, you can't visualize these seizure. That's why we put electrodes of EEG. We monitor seizure by EEG, and we put electrode at right frontal, means non-dominant brain. Question. But most commonly we use bilateral. Indication of ECT, most common indication, wherever you find there is patient is having suicidal tendency, then you will use electroconvulsive therapy. Okay, other than catatonia, the treatment of choice of catatonia is electroconvulsive therapy. Question. This is ECT machine. Yes. Now this is RTMS. RTMS, recurrent transcranial magnetic stimulation. Yes, recurrent again and again transcranial magnetic stimulus. There is a Faraday's law, means when you put magnetic field, it can generate electric field. So you put a magnetic coil. This is magnetic coil, and due to this magnetic coil, this produces electric field in the brain. And you can stimulate a specific area of brain. So advantage of RTMS over ECT is that there is no need to give general anesthesia, because we are not producing seizure. We are stimulating the area of brain without seizure. And we can stimulate a particular area, not generalized. Okay. And this is, question is asked, this is 8 shape, figure of 8. Shape handheld, means the person is having this machine in hand. There is no need of general anesthesia, so patient is conscious. Yes, so this is RTMS. So you can easily differentiate RTMS from ECT. In ECT, the patient is unconscious and we use mouth gag. Yes, mouth gag to prevent tongue bite. And in this, the patient is conscious. Question. RTMS is approved for depression, OCD, and post-traumatic stress disorder. Depression, OCD, and post-traumatic stress disorder. Next test is test for organicity. Yes, means brain lesion. If you want to detect brain lesion, you can detect by Bender visual motor Gestalt test. Yes, you can remember by the name only, visual motor, means this assess coordination or integration of visual and motor activity. Used for organic brain damage. Yes, it consists of 9 separate designs and patient is asked to copy these designs. So just have a look. These simple design patient is asked to copy, and if patient is not able to copy these properly, then we think there is some organicity. So this is test of organicity. Niemann's question. Yes, they showed this image and asked what is this test. That is Bender visual motor Gestalt test. Or sometimes they will not use visual motor, Bender Gestalt test. Phineas Gage skull. Phineas Gage was a train driver. He got an accident, and in that accident an iron rod, yes, an iron rod penetrated through his skull. Yes, this is Phineas Gage skull, and by operation this rod was removed, patient was saved. But after that, patient was having change in his behavior. Patient was having disinhibited behavior, aggressive behavior, and this is found that there was frontal lobe damage, and this is typical example of frontal lobe syndrome. Frontal lobe syndrome. In frontal lobe syndrome, there is disinhibition, aggression. How questions are asked? A patient present with habit of urination in public, means disinhibition, does not have any feeling of guilt or remorse for the same. Which cerebral lobe would be involved? And I told you that is frontal lobe syndrome. And Phineas Gage, that was train driver who suffered an injury. Iron rod passed through his skull. Patient was saved, but changed his behavior. Frequently asked question, favorite question of MCI, delusion of misidentification or misidentification syndrome. First is Capgras. They are very close. Yes, they twist the language and you are confused. So remember the example and you will solve the question very easily. First is Capgras. Let me give you an example. There is a lady in ward. She says that the husband who is staying with her is not my husband. Means her husband, she says that my husband is not my husband. He is somebody else who is looking just like my husband, who is behaving just like my husband, who is talking just like my husband, but he is not my husband. When she was asked, why are you saying like this? She said that he is wearing a cap, Capgras. So just to add humor and mnemonic, Capgras means patient believes that familiar person has been replaced by similar looking stranger. So you will remember the example, means familiar person, her husband has been replaced by similar looking stranger. She says that her husband has been replaced by somebody else who is looking just like her husband, who is talking just like her husband, who is behaving just like her husband, but he is not her husband. Capgras syndrome. Got what is Frigoli syndrome? Again, let me give you example. A patient says that the beggar sitting outside is not a beggar. He is my boss. He has changed his physical appearance, just like he has weared a mask of beggar. So the patient says that the beggar sitting outside is not beggar. He is a person. Yes, he is my boss and he has changed his physical appearance. Yesterday, I met a policeman. That policeman was not policeman. He was my boss again, who was keeping an eye on me. Yes, he changes multiple physical appearance. That is Frigoli. How to remember? I took beggar example. Beggar take everything free. So Frigoli, beggar example. Again, I repeat, questions are asked. They twist the language. So don't get confused. Just remember the example and you will solve the question. Patient believes that familiar person is changing his physical appearance. Yes, familiar person means boss is changing his physical appearance just like beggar, and he can take multiple different appearance. Yes, he can take appearance of beggar, he can take appearance of policeman. And yes, picture MCQs, this, yes, he can change his physical appearance just like a person can change his physical appearance by putting different mask. That is Frigoli syndrome. Very frequently asked question, recently asked question, BPAD, bipolar affective disorder, type 1 and type 2. BPAD. Yes, first thing, in BPAD 2, you will remember there is depression plus hypomania. Means if a patient comes to you and he says, yes, or you took history and you found the patient is having multiple episodes of depression, 1 episode, 2 episode, 3 episode. Yes, number is not significant. Episode of depression and episode of hypomania, not mania, hypomania. Okay. Hypomania episode may be multiple, depression episode may be multiple, number does not matter. If depression and hypomania only, then you will say this is BPAD type 2. Other than these, all are BPAD type 1. So, a question is asked, yes, this is a graph of a patient. Yes, in this patient, yes, this is depression, this is mania, this is hypomania, so this is depression. Okay, so this is BPAD1. BPAD1. Yeah, I told you, if depression or hypomania, then BPAD2. Other than that, all are BPAD1. Yes, common example, BPAD1, depression plus mania. You will find a question, a patient is having mania, depression. This is BPAD type 1. A person is having mania, depression, hypomania, just like in this case, BPAD type 1. A person is having mania. Yes, this is again BPAD type 1. Even if no depression, only and only mania, multiple episodes of mania are there, you will say this is BPAD type 1. Yes, remember this, multiple episode of mania. It is again bipolar. You will say that if second pole is not touched, means depression is not there, then why we say it is bipolar? We found that in future this patient will develop depression. So BPAD type 1. Clear? Now next point, next image, that is Vera-Guth fold. This is sign of depression. Yes, we always discuss symptoms of depression. Yes, the patient tells us that I am having depression, I am having sadness of mood, I am having loss of interest, I am having decreased appetite, decreased sleep. Yes, patient is having decreased psychomotor activity. Yes, these are symptoms of depression. But what is sign of depression? Yes, in which clinician find that there is triangular fold at the nasal side of upper eyelid. Triangular fold at nasal side of upper eyelid. That is Vera-Guth fold. Vera-Guth fold. Yes, seen in depression. Now I am going to tell you a very important flow diagram. Yes, that is depression. In depression, you all know symptoms are low mood, decreased appetite, decreased sleep, decreased psychomotor activity, decreased concentration, decreased interest, decreased energy. And you know, according to DSM-5, yes, if you want to make the diagnosis of depression, there should be 5 symptoms. There should be how many symptoms? 5 symptoms. But if a patient comes to you having these 4 symptoms, low mood, appetite, psychomotor activity, sleep, means total 4, means not fulfilling the criteria of depression, yes, then these symptoms continues for 2 years. Then you will say the patient is having dysthymia. So, subsyndromic symptoms of depression, dysthymia. Now, this dysthymic patient also develop decreased interest, means now 5 symptoms are there, means now you will say the patient is having depression. So, a dysthymic patient was there, you diagnose the patient having dysthymia. Now, in this patient, yes, the criteria of depression is fulfilled, then you will say that this is double depression. Question is asked, what is double depression? Yes, double depression is dysthymia plus depression. Dysthymia plus depression is double depression. So, these 5 symptoms, diagnostic criteria of depression is fulfilled if these symptoms are present for 14 days. Question: to make the diagnosis of depression, major depressive disorder, yes, duration should be 14 days. To diagnose mania, the duration should be 7 days. Then you will make the diagnosis of major depressive disorder, means symptoms of depression for 14 days, fulfilling the criteria, major depressive disorder. If you took history and you found that patient is having past history of depression, means he is having more than one episode of depression. Question is asked, they will give you these symptoms and they will give there in the past patient was having these symptoms for which he was treated. then you will say it is recurrent depressive disorder. The diagnosis would not be major depressive disorder. The diagnosis would be recurrent depressive disorder. But in the same question, same symptoms are given and they give the patient develop these depressive symptoms only in winters. Every time in a season, particular season, seasonal affective disorder. Seasonal affective disorder. And a question is asked in seasonal affective disorder, the treatment is phototherapy. Question is asked, phototherapy is used in seasonal affective disorder. It is a type of recurrent depressive disorder. If a patient, yes, I again tell you, these symptoms would be more or less same. You know that symptoms of depression. And if history is past history of depression, recurrent depressive disorder. If past history of hypomania, if you took history and patient gave history, past history of hypomania, then the diagnosis would be BPAD2. You all know, yes, you all know that BPAD2, there is depression and hypomania. If same question, same symptom would be there, these symptoms are there, and patient gave that in the past patient was very active, overactive, increased sexual desire, decreased need of sleep, yes, over talkative, over familiar, means patient was having symptoms of mania, patient was admitted, means mania is there. Then the diagnosis would be BPAD1. I told you depression, yes, I just told you depression plus mania, BPAD1. Depression plus hypomania, BPAD2. So these are common clinical questions. Now, if we talk about, yes, dyslexia, specific learning disorder, SLD. In SLD, this is specific reading disorder. Dyslexia is specific reading disorder. Specific learning disorder include multiple things. One of them is specific reading disorder, dyslexia. You all know Tare Zameen Par, the movie. Yes, in this the patient sees mirror image. Yes, A, mirror image of letters P, Q. So you will find this picture MCQ and they will ask, this is typical example of dyslexia. One important point you must know that in dyslexia or specific learning disorder, IQ should be normal. IQ should be normal. If IQ is less, then you will not make the diagnosis of dyslexia, you will make the diagnosis of intellectual disability. Now we come to next image. Yes, many times you will find the same question and confusing. Yes, catatonia. Look at the image. If a person is in ward and patient is having this posture. Yes, you entered the ward and patient is acquiring this abnormal posture and maintaining this posture for a long time and he is or she is doing it spontaneously. I write here spontaneously. You are not doing anything. Then you will say posturing. The answer would be posturing. How question is asked, they will show you the image and they will say that when you entered the ward and you saw the patient in abnormal posture, he was maintaining or she was maintaining this posture for a long time. Diagnosis is or phenomena is posturing because patient acquired it spontaneously. But if you are doing examination, you are doing passive movement. In passive movement, you feel no resistance and final posture is maintained. Then it is catalepsy. Means no resistance, but final posture is maintained. They will say that how questions are asked, they will show the same image. We will say that when you are examining, yes, there is no resistance, and when you leave the patient in an abnormal posture, the patient maintain that abnormal posture. This phenomena is catalepsy. But in passive movement, if you feel resistance, just like you are bending wax candle, then and final posture is maintained, then it is waxy flexibility. You must remember catalepsy from, you must differentiate catalepsy from cataplexy. Cataplexy. Cataplexy is seen in narcolepsy. Yes, narcolepsy, daydreaming, yes, is a disorder in which patients sleep in daytime. Cataplexy is sudden loss of muscle tone. Sudden loss of muscle tone, patient is standing and there is sudden loss of anti-gravity muscle, patient will fall down. And patient would be conscious at that time. In cataplexy, patient will fall down and the patient is conscious. Remember this point, many times in clinical question you will find this, patient is conscious in cataplexy. So how to remember? Simple. Yes, lepsy, narcolepsy is not having lepsy. Okay, catalepsy is seen in catatonia. Yes, narcolepsy is having plexy. Now lithium, yes, we can't ignore lithium. Many times questions are asked, lithium is behaving just like sodium in our body. So as you know, sodium is not metabolized in our body, so lithium is not metabolized. Sodium is controlled by, sodium is managed by kidney, so lithium is also excreted by kidney. Yes, no plasma protein binding, sodium is not binding plasma protein, lithium is not binding plasma protein. It is having narrow therapeutic index. Point it out, the therapeutic level is 0.6 milliequivalent per liter to 1.2 milliequivalent per liter. But if it goes beyond 1.5, then it causes toxicity. Question is asked, half-life of lithium is 1.3 days. Yes, and you all know that plasma steady state concentration is achieved 4 to 5 half-life. Question in pharma. Yes, so lithium plasma steady state concentration will be achieved after 5 days, approximately 5 to 7 days. So if you started lithium, after how many days you will check the lithium level? Yes, question is asked after 5 days. Yes, you started lithium today, then you want to check the level of lithium. Yes, you will check the lithium on 5th day. Yes, and when you will take the sample, you will take sample to estimate serum lithium after 12 hours of last dose. Question means if patient took last dose in the night at 9 p.m., you will take the sample at 9 a.m. This image shows Russell sign. This is Russell sign seen in bulimia nervosa. Yes, in bulimia nervosa, there is binge eating and purging. Yes, binge eating. What is binge eating? Means patient take large amount of food in a short time, but patient is conscious about weight. So what happens to compensate this binge eating, large eating? Yes, patient do purging. Purging is a compensatory mechanism. He may do or she may do. Yes, better to say she, because bulimia nervosa is more commonly found in females. She would do vomiting. She will induce vomiting. When she will induce vomiting repeatedly, then incisor strike on the knuckles and there will be formation of callus formation. This is callus formation on the knuckle and this is called Russell sign, seen in bulimia nervosa. Other than this Russell sign, you will find in bulimia nervosa dental caries. Dental caries would be there. Yes, one important question which can be asked, that anorexia nervosa, binge eating and purging type, binge eating and purging type. Means anorexia nervosa may be of two type. One is restricted type. In anorexia nervosa, patient is not taking large amount of food or not taking food. Yes, that is restricted type. In anorexia nervosa, binge eating and purging type, patient do binge eating and after do that purging. So in that case, yes, the patient may show Russell sign. Okay, so question is asked that bulimia yes, Russell sign is present in option A bulimia nervosa, option B anorexia nervosa, binge eating purging type. Yes, best answer would be bulimia nervosa. But if both options are given, option C both of the above, the answer would be both of the above. One very important question point or key point, how to differentiate between bulimia nervosa and anorexia nervosa. You can differentiate by BMI. If BMI is less than 17.5, then the answer would be, yes, answer would be anorexia nervosa, binge eating and purging type. And if BMI is more than 17.5, then it is bulimia nervosa. Now we come to body focused repetitive behavior disorder. Yes, this is included in ICD-11 as a part of obsessive compulsive and related disorder. Yes, body focused repetitive behavior disorder include two disorder, excoriation and trichotillomania. Yes, this is picture MCQs. They will show this picture and will ask, this is trichotillomania. Yes, in trichotillomania, patient has intense urge to pull his or her hairs, okay, and there may be a patch of baldness. So, trichotillomania, frequently asked question. Previously, it was impulse control disorder. Impulse control disorder. Previously, it was classified as impulse control disorder, but now it is classified as obsessive compulsive and related disorder, trichotillomania. What is excoriation disorder? Means patient is preoccupied or doing repeatedly, yes, picking of skin, and he will do or she will do this picking of skin so frequently up to when there is lesion. So this is excoriation disorder. So in both of these, excoriation and trichotillomania, yes, these two combined, yes, there is focus is body and patient do repetitive behavior. That's why body focus repetitive behavior disorder. Yes, in this, yes, if a person is doing this like this and pulling airs like this, you will say what the bad habit you are having. So you will say reverse your habit. Reverse your habit. So treatment, behavior therapy is habit reversal therapy. Habit reversal therapy. So question is asked, habit reversal therapy is used in trichotillomania, excoriation disorder, one more, Tourette syndrome. Tourette's syndrome. In Tourette syndrome, what happens? Yes, you must have seen the movie Hitchcock. Yeah. Brief, rapid, recurrent, intense urge to perform and motor activity and vocalization. So, motor activity, motor tic, vocalization, vocal tic. So, in Tourette syndrome, there is at least one vocal tic and multiple motor tics. So, Tourette syndrome. In Tourette syndrome, yes, treatment, behavior therapy, habit reversal. Trichotillomania, habit reversal. Excoriation, habit reversal. Yes, motor tic may be like this, shrugging of shoulder. So, if a person is doing like this, you will say what a bad habit you are having. So, reverse these habit. So, habit reversal therapy. This is a kind of mnemonic, you will remember. Next topic is stage of death and dying. Recently asked question in MCI given by Elizabeth Kubler-Ross. If a person comes to know that he is going to die, he is having lethal disease, he is having terminal illness just like cancer, HIV, then he may go through these stages. Suppose a person comes to know he is having cancer, he will immediately say, no, 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 how can it be possible? I have never smoked, I have never taken alcohol, how can I have cancer? This is denial, and he will be shocked. So first stage is, yes, denial and shock. Then he would have anger towards God, towards family member. Yes, why me? Why me? Hey God, why me? It's not agitation. Agitation. Question was asked in MCI. Yes, they ask, yes, which of the following is not stage of Elizabeth Kubler-Ross or stage of death? Yes, and they gave agitation in place of anger. So, in stages of death and dying, there is anger, not agitation. Okay, remember this point. Bargaining. Yes, when he would be angry after some time, he would bargain to God. Hey God, just save me. I will never do this. I will never do that. Yes, I will never take alcohol. Okay. So this is bargaining. Then depression. When he would come to know that there is no benefit of this bargaining, he would go in depression. Yes, he would go in depression. And ultimately he will accept. Okay, now yes, I am going to die. Now the time, whatever I am having, I should enjoy that time. That is acceptance. So mnemonic is DABDA, D-A-B-D-A, DABDA. A frequently asked question, withdrawal symptoms of opioid. You all know that opioid cause, yes, meiosis. In opioid intoxication, question is asked, intoxication, there is a triad of respiratory depression, meiosis, and coma. Means patient is having respiratory depression, meiosis, and coma. Question is asked, in opioid intoxication, first treatment, first step or initial step is secure airway. Yes, and treatment of choice is IV naloxone. Yes, IV naloxone is opioid antagonist. So we do remember that we immediately inject, yes, naloxone. But before injecting naloxone, we secure airway. So question was asked most of time, student remember IV naloxone? No. First step is secure airway, but the treatment of choice remains same, opioid antagonist, that is IV naloxone. This is opioid intoxication. If opioid is withdrawal, yes, if patient is taking opioid for a long time, now not taking, means withdrawal symptoms would be there. Flu-like symptoms. You all know in flu, yes, there is lacrimation, increased lacrimation, redness of eyes, rhinorrhea, nasal secretion increase. You remember one mnemonic, simple mnemonic. All secretions are increased. What I said? All secretions are increased. Nasal secretion, rhinorrhea. Eye secretion, lacrimation. GI secretion, diarrhea. Body sweat gland secretion, increased sweating. Patient would have yawning. This is specific. Yes, this is specific to opioid withdrawal. Piloerection. The patient would have goosebumps. Yes, again, very important questions are asked. Mydriasis. I told you toxication, meiosis. Yes, withdrawal, mydriasis. Body ache, insomnia. These are common withdrawal symptoms of opioid. Alcohol withdrawal, frequently asked question. First symptom means after 6 to 8 hours, yes, tremors would be most common. Other than tremors, nausea, vomiting, anxiety would be there, but most common is tremors. Many times you will find the patient is taking alcohol for a long time. Yes, he took alcohol in the night at 10, 11. He took a good sleep of 6 to 8 hours. In the morning, he start having shaking hands. That's why in the morning, he take alcohol. In many movies, you must have seen that hero or sometime villain take alcohol immediately after getting up. The reason is, yes, he start having tremors. So, question, most common alcohol withdrawal symptom, tremors. If patient is not taking alcohol for 12 to 24 hours, then alcohol hallucinosis. Hallucination may be there. Auditory hallucination. Alimentary hallucination. After 24 to 48 hours, there are seizures. How to remember? Seizure, SE, for second day. Second day. They ask, particularly in MCI, they ask on the duration, question on duration. Second day seizure. Second day means between 24 to 48 hours. And these seizures are not partial. These are generalized tonic-clonic seizures and they comes in clusters. Clusters means in a short time there are multiple seizures. In after 48 hours to 72 hours means 2 days to 3 days. Delirium tremors, you can easily remember D, die, do. Three, try, 3, 2 to 3 days delirium tremors. Yes, questions are asked that delirium tremors usually develop between 2nd and 3rd day. You all know what is delirium. Let me describe. Long clinical question you will find on delirium. Yes, if you find long clinical question, patient is having hallucination, delusion, abusing word, he is aggressive, and you will find a word that patient is disoriented. Catching point for delirium, I am telling you. Yes, I am not telling about delirium tremors for the time being. I am telling you about delirium. Delirium may have so many causes. Yes, in clinical question, you may find the patient has history of surgery, patient has femur fracture, patient is having severe burn, after patient electrolyte imbalance, after that patient started abusing, pulling cannula, yes, talking to somebody who is not there, yes, means hallucination. These are symptoms of delirium. And in these, catching point would be disoriented, disorientation to time, place, person. Sometimes you will find the word clouding of consciousness, clouding of consciousness. Altered sensorium. So, if you find these words, disoriented to time, place, person, clouding of consciousness, altered sensorium, yes, you will mark the answer delirium. Okay. But if a question you find that in this question, patient is also having autonomic hyperactivity or instability, sometimes word use instability. Autonomic instability, hyperactivity, increased BP, tremors, sweating, diaphoresis word. Yes. So, other than these symptoms of delirium, you find autonomic hyperactivity and instability. Yes, you will mark the answer delirium tremens. So, delirium plus tremors, you will remember like this, delirium plus tremors, delirium tremors. Many times in question of delirium tremors, you will find that there is history of alcohol use. Question, history of alcohol use would be there. Yes, but there are few questions in which you will not find history of alcohol use. Typical symptoms of delirium would be there and autonomic instability would be there. You will mark delirium tremors without history of alcohol use. Yes, don't get confused that if they have not given alcohol history, you will never mark delirium tremors. No. This is written in latest edition of Synopsis, clearly written that first many times these patients having delirium tremens are diagnosed having substance use history on development of these symptoms. Means many times patient don't tell that they are taking alcohol, but when they are, yes, abstinent from alcohol for 3 days, 2 days after surgery, they develop these symptoms. So remember, again I am telling you what happens. Many times we don't have history of alcohol use and we rule out delirium tremens. No, there may be possibility. If typical symptoms of delirium tremens are there, you will mark delirium tremens. Okay, what is the treatment of delirium tremens? Yes, IV lorazepam. Yes, in few questions you may not find IV lorazepam and they will give you tablet chlordiazepoxide. Chlordiazepoxide. Yes, in Synopsis it is written that we can give orally 50 to 100 milligram chlordiazepoxide. Yes, in patient of delirium tremens. So we can give orally chlordiazepoxide, but if patient is unable to take oral, then we use IV. We can give IV lorazepam. But NICE guideline says that IV diazepam. So never, don't get confused. Best answer is IV lorazepam. Okay. But if they don't give and they give tablet chlordiazepoxide, this may be the answer. Few questions. Okay. One more question in delirium. Yes, delirium is also called ICU psychosis. Yes, ICU psychosis. So question is asked in delirium. Yes, not I am not talking about delirium tremens. I have told, yes, about treatment of delirium tremens. Now I am talking about delirium, also called ICU psychosis. In this, we can give low dose antipsychotics. Antipsychotics. You can easily remember psychosis, antipsychotic. Now cocaine, frequently asked question of MCI. Questions are asked, cocaine, yes, you will remember by the name Coca-Cola. There is jet black tongue. Sometime in question you will find jet black buccal mucosa. So color of Coca-Cola you can see, yes, you can match the color of Coca-Cola with jet black tongue. In cocaine use, if you are using cocaine regularly, yes, there may be nasal septal perforation. How to remember? Yes, in Punjabi, coca. Yes, coca, nasal septal perforation. One more question. There, cocaine use produce tactile hallucination. Tactile hallucination. Yes, by the name I usually tell, you can make many mnemonic. Yes, by the name only. Cocaine, cockroach. Cockroach is a bug. Cocaine bug. You will find clinical question, a patient taking a substance now feel that insects are crawling under the skin. Yes, the most probable substance is cocaine. Cocaine bug. Okay. Types of schizophrenia. For yes, for FMG you can't ignore. Yes, this topic. Yes, paranoid schizophrenia, P4 paranoid, P4 positive symptoms. P4 positive symptoms. Yes, in paranoid schizophrenia, positive symptoms are delusion plus hallucination. So many times you will find clinical question in which you will find they will give the patient is having delusion, hallucination, and personality is intact, patient is behaving normally. Yes, otherwise patient is normal. The diagnosis is paranoid. Paranoid is usually late onset. Late onset means more than 45 years. Question is asked, what is late onset? 45 years. This is having good prognosis. Good prognosis. Question. Catatonic schizophrenia. Yes. Catatonic schizophrenia. I told you few catatonic symptoms just like flexibly, posturing. Yes. Catalepsy. Other than negativism, echolalia, echopraxia. What is echolalia? Question has been asked. Echolalia means echo of language. Whatever you are saying. Suppose I say, what is your name? Patient would say, what is your name? Where do you live? Where do you live? Echolalia. Echopraxia. Praxia means motor movement. Yes, if you do like this, patient will do the same thing. Echopraxia. These are symptoms of catatonia. Question: catatonia is most commonly associated with depression. Yes, this may be confusing, but remember, question was asked previously. We used to say catatonic schizophrenia. Yes, means schizophrenia may be of catatonic type, but now we say catatonia is a separate diagnosis. It may be present in schizophrenia, it may be present in depression, and most common cause of catatonia is depression. Question. Okay. Medical cause of catatonia is hepatic encephalopathy. Hepatic encephalopathy means a patient having hepatic encephalopathy may have catatonia. Now, question is asked: catatonia best prognosis. Best prognosis. Catatonic schizophrenia is having best prognosis. Initial treatment is lorazepam. Injection lorazepam. Yes, question is asked: if a patient of catatonia comes to you, yes, you will start treatment, the immediate treatment, then you will say, yes, injection lorazepam. But if they ask treatment of choice, I have already told you, modified ECT according to Mental Health Care Act. Direct ECT you can't give, so modified ECT. But a question is there in which they will say that the patient is unstable. Patient is having catatonia and patient is unstable. Malignant catatonia. Okay, I don't confuse you. Simply, if you find that patient is unstable, yes, he may harm himself or other person or family member, then you will not try injection lorazepam. You will immediately give modified ECT. So when questions are asked, they confuse you because you know initial treatment we try lorazepam. Yes, if patient is not improving by lorazepam, then we give modified ECT. But in life-threatening situation, yes, means the patient has danger to his own life or others' life, then you will immediately give modified ECT. Okay. Third is hebephrenic or disorganized. Disorganized schizophrenia. In disorganized schizophrenia, you will find that abnormal behavior means disorganized behavior, disorganized thought. Disorganized thought means formal thought disorder. Formal thought disorder. Yes, derailment, loosening of association, incoherence, neologism. Again, I repeat, derailment, incoherence, loosening of association, neologism, circumstantiality, tangentiality, thought block. Yes, many times you will find a question, the patient is talking, immediately stops. And when you ask patient, he is not replying. That is thought block. So, means formal thought disorders, disorganized behavior is seen in hebephrenic. So, hebephrenic main would be disorganized. Simple schizophrenia, only and only negative symptoms for 1 year. Yes, this is very important. Simple schizophrenia duration criteria in 1 year, only negative symptoms means amotivation, anhedonia, decrease interest, apathy, amotivation. Yes, no motive in the life, no concern. Okay, that these are negative symptoms for 1 year, then we say simple schizophrenia, and this is having worst prognosis. Worst prognosis. So these are frequently asked question. Now, if these symptoms, out of these 2 or more than 2 symptoms, okay, I have tried to integrate, okay, means delusion. Let me highlight. Delusion, hallucination, yes, catatonic symptom. Third, disorganization symptom. 4, negative symptom. 5. Out of these 5, yes, if 2 or more than 2, symptoms are present, if 2 or more than 2 symptoms are present for less than 1 month, then you will say brief psychotic disorder. Brief psychotic disorder. Okay. Again, I am repeating, types of schizophrenia is given in ICD-10. DSM-5 has removed these types. ICD-11 has removed these types of schizophrenia, and questions are asked if these symptoms I have highlighted 5 symptoms. Out of these, if 2 or more than symptoms less than 1 month, brief psychotic disorder or acute psychosis. Acute psychosis. Or sometimes ATPD, acute transient psychotic disorder. 3 names. Same symptoms, 3 names you will find in questions. Less than 1 month, this. If these symptoms are present for more than 1 month, but less than 6 months. If question is asked and these symptoms are present for more than 1 month and less than 6 months, then schizophreniform. Schizophreniform disorder. But if 2 or more than symptoms are present for more than 6 months, then you will diagnose schizophrenia. So schizophrenia, according to DSM-5, symptoms should be more than 6 months. But again, I repeat that for diagnosis of simple schizophrenia, the duration of symptom, negative symptom, 1 year according to ICD-10. Next is few named schizophrenia. Yes, von Gogh schizophrenia. Von Gogh schizophrenia. Yes, Van Gogh was a famous painter who was having schizophrenia, and he cut his ear during active schizophrenia. So a picture MCQ was asked. They gave this picture and yes, this is deformed ear or cut ear. Yes, and they asked which type of schizophrenia. Van Gogh schizophrenia means schizophrenia patient if do self-mutilation. Self-mutilation means self-injury. If question is asked, they give a clinical question that patient is having schizophrenia, delusion, hallucination, and under hallucination patient cut his ear, cut his hand or self-mutilate, then it is Van Gogh schizophrenia. This is oneroid schizophrenia. Oneroid schizophrenia. A picture MCQs. This is a vivid scenic picture. Vivid scenic picture. Yes, oneroid means dream-like state. Yes, the patient see vivid scenic picture, and this is usually seen in catatonic schizophrenia. Oneroid word is used. Now we discuss few parasomnias, potential topic for MCI. Yes, parasomnia means pale to sleep, which is happening during sleep. You all know that stages of sleep, stage 1, stage 2, yes, stage 3 and stage 4. Stage 2 is largest stage. Yes, largest phase of sleep. Yes, this is NREM. And then there is REM sleep. Yes, so stage 1, 2, 3 and 4. Yes, stage 3 and 4 are deep sleep. These are deep sleep. Now it is called M3. Stage 1 M1, stage 2 M2. Question is asked, stage 2 is largest and there is stage 2 sleep spindle. Sleep spindle. K complex. K complex or sleep spindle is found in which stage? Stage 2. Stage 3 and stage 4, yes, these are deep sleep, also called M3. And question is asked that in stage 2, the disorder parasomnia is bruxism. Bruxism. While in stage 3, yes, stage 3 or M3, stage 3 or 4, M3, night terror, somnambulism, somnolurky, means sleep talking, somnambulism, sleepwalking, bruxism, yes, I have already told you, these are parasomnia of NREM. Now, question is asked, yes, REM sleep, there is nightmares. So, night terror and nightmares. Many times questions you are confused. Yes, simply you can remember, yes, mare, yes, REM, mares, S replace RM. So, nightmares in REM sleep. In REM sleep, we see dreams and we remember these dreams. What happens that in nightmares, patient would wake up and would remember the dream. He would not be terrified. He would not be terrified, no autonomic hyperactivity, and patient will remember the dream. So, questions are asked, they will give similar picture and you will differentiate between night terror and nightmare simply by sympathetic activity. Patient would be having increased heart rate, perspiration would be there, tachypnea would be there. Yes, means night terror. Patient is terrified. Okay, that is NREM sleep. Okay, somnambulism, sleepwalking. Patient walk in the sleep. You must have seen in many movies. In this, we say, don't wake up these patients. Otherwise, sometimes these patients harm you. So, sleepwalking, sleep talking, talking during sleep, these are, yes, part of NREM, or these are parasomnias of NREM M3. While bruxism is stage 2 NREM. While nightmares, yes, nightmares in REM sleep. Frequently asked question. Treatment for these is reassurance. Yes, questions are asked that a patient, 7-year-old patient comes to you with parents and the parent says that he is having the night walking, okay, means somnambulism. Yes, what is the treatment? Treatment is reassurance, because when they will in adulthood, they will go in adulthood, these symptoms will resolve, somnambulism will resolve itself. You will secure the, yes, environment so that patient should not harm himself or herself during sleepwalking, and reassure the patient. But if patient is not improving, or yes, second line treatment is benzodiazepine. Sometimes, yes, if patient is not improving, then you can think of benzodiazepine. Why benzodiazepine? Yes, benzodiazepine decreases M3. You all know that somnambulism occur in M3. So, if phase of a duration of M3 is decreased, then the chances of somnambulism will be decreased. So, other than these important topics, let me tell you few strategies by which you can increase the chances of performing well in your exam. First things, take a good sleep. Yes, good sleep is very important, because you know that all the learned material is processed during REM sleep. When we take REM sleep, yes, short-term memory is converted to long-term memory. This is a question. Okay, so take a good sleep. Second, sleep hygiene. Yes, what is the point? What are the points of sleep hygiene? Yes, go to bed on a fixed time, wake up at the fixed time, do regular exercise. Okay, so taking sleep is very important, and again I give stress of 10-minute exercise in the morning. Why I'm giving you stress? Because 10-minute exercise will make you alert the whole day. Okay, don't exhaust yourself, just 10 minutes. It will prevent depression, it will improve your memory, it will decrease your anxiety. Many times you are having so much of anxiety, that's why you can't perform better in your exam. So take proper water content, should be normal, as you know it's a hot summer, so adequate hydration is important. And try to check your center where you are going to appear in your exam, so that you should not have anxiety. Okay, reach your center at least half an hour before the suggested time. Okay, so that you must not have anxiety in the morning. So these are few important things you should follow. Other than that, you should remain positive. You have worked hard, Yes, if you have worked hard, you will clear your exam. This positive thinking will increase your performance. Yes, there is a concept of unconscious mind that we have all the information in our unconscious mind. Our unconscious mind determine our behavior. A question is asked on psychoanalysis. Yes, unconscious mind determine our behavior. So in few conditions, unconscious thing can come at the surface. Means if you are positive, then the information which is present at your unconscious mind will come at the surface and will help in your exam. The only thing is believe in you. You have worked hard. If you have worked hard, definitely you will clear your exam. Just trust yourself. Okay, best of luck.